I don't know if everyone was here earlier, but my name is Buckley McCall. I'm a first-year internal medicine resident at Prisma Health Upstate in Greenville, South Carolina, and I am the new chair of the Physicians and Training Committee. So thank you all for being here. I really appreciate you all coming, and let's learn a lot today from each other and make connections and meet people we wouldn't otherwise meet. Today, I'm going to talk about recognizing tracheal stenosis in the outpatient setting, which isn't typically the place that you see tracheal stenosis, which is probably what makes it more complicated than you would think. This is a case of a 39-year-old gentleman who was recently admitted to the ICU for a hypoxic hypercapnic respiratory failure, and he required intubation for airway protection in the setting of hypercapnia and confusion. He was intubated for 4 days in the ICU, just kind of vent weaning, maintaining treatments, and was ultimately extubated, thankfully, and he had stridor on extubation. When you extubate someone who has stridor, you think of tracheal stenosis kind of in that acute setting, and you give racemic epinephrine, Decadron, sometimes Benadryl, and then he was extubated NIV as well. His stridor kind of improved with those initial treatments, and he was no longer stridulous, and ultimately was able to wean his oxygen continuously and pass a home O2 walk test, transfer to the floor, and then go home without any supplemental oxygen. So he had this complicated course and improved, and then was set up with pulmonology follow-up, as you should be whenever you're intubated in the ICU for respiratory failure. So about 39 days later, I guess 5.5 weeks, he was seen in a pulmonology office, at which point when he walked in the door, they noticed that he was having stridor with his breathing. And when, I guess that's a pretty good place to be if you're having stridor, would be a pulmonology office. But looking at this chest x-ray, it doesn't look terrible. Some bilateral infiltrates, nothing that we wouldn't normally see in a pulmonology office. But up here at the top, it's kind of difficult to see with quality and everything, but you can see there is indentation of the trachea on this chest x-ray that they were able to get in the pulmonology office. So he walked in stridulous. The pulmonology physician said that that's not good. Let's go ahead and get a chest x-ray and see where we're at from an oxygen standpoint. And then on chest x-ray, noted to have this ingoing of the trachea concerning for some stenosis. So being that we're in a pulmonology office, we had more facilities and tools at our disposal. So in office, he was able to have pulmonary function test, which is a beast in and of itself to manage and tackle. But you have 4 iterations of PFTs right here, and they all resemble that kind of closed fixed loop that you think of in medical school when you learn your PFTs for a fixed obstruction. So 1, 2, 3, 4, none of them were mistakes. So seeing the chest x-ray, we said that's concerning. So luckily on the medical campus, the pulmonology office was on, there's a high-res CT scanner next door. All this is kind of falling nicely into play. So went next door for a high-res CT scan, long trachea, and you can see kind of very similar to at that thoracic inlet outlet area, a obstruction of the trachea where it's ingoing, which is consistent with tracheal stenosis. In this setting, given that we were in a pulmonology office, we had the facilities and tools, and he's oxygenating well, doing all right, we were able to set him up with a bronchoscopy 2 days later. So he went from pulm office, home, 1 night sleep, another night sleep, next thing, first thing in the morning, the next day he had a bronchoscopy. They went in and they found that he had tracheal stenosis right at that intrathoracic, extrathoracic kind of border, and he was noted to have a 20% opening that was hard and fixed on bronchoscopy. So in doing so, this is more so interventional pulmonology. They went in, dilated with a balloon to spread it out as they were able, cutting with electric artery and dilating again to further expand this tracheal stenosis. And then thereafter, he was extubated and doing all right. And then he was scheduled for a repeat bronchoscopy in 2 weeks. At that 2-week mark, it noticed they looked like the tissue had kind of gone in again and was stenosing, which is not unexpected because no matter how far you push something out with a balloon, there's going to be some rebound. Went in, they did the same thing, further dilation, larger balloons, and they took some biopsies at that time just to kind of see, hey, is there anything that we could be missing about this? Is there any path that we're missing? Interestingly, on biopsy, it came back with an insufficient tissue sampling, but it was noted to be positive for amyloid staining, which is pretty niche and interesting for tracheal amyloid in a 39-year-old gentleman with not a ton of past medical history outside of COPD. So had his repeat bronchoscopy, and then tissue sampling came back with insufficient staining for amyloid, and they would need further sample to go forwards. I am going to talk a little bit about tracheal stenosis and unfortunately flow volume loops for everybody. Tracheal stenosis is something you think of after intubation with illness and infection and with autoimmune conditions. Most notably in children, you think stridor, whooping cough, things like that. Croup is one of the main ones where you have the steeple sign. It was on the sketchy video for tracheal stenosis. And the adults, in terms of infection, tuberculosis is one of the main infections that cause tracheal stenosis. Far and away, intubation and extubation and subsequent tracheal stenosis is most common. This is not something that you want to have to deal with in the outpatient setting, especially if you're not in a dedicated pulmonology office. So I think that's something that I would like to relay here if I get any message across, is kind of the severity of something like this. And when someone comes in stridulous, generally speaking, that is a borderline emergency. Most offices don't have the facilities like X-ray, pulmonary function test, high-res CTs, and scheduling a bronch in 2 days. That's just not something that's feasible at offices. And going into stridor, I don't know if anyone's heard stridor before. It is an interesting physical exam finding. So your lungs are relatively clear at the bases, but you'll listen peritracheally and you'll have loud, like rhonchorous sounds. And also it's not discriminatory, inspiratory, or expiratory. So you have inspiratory and expiratory stridulousness. And someone might be satting all right. Their O2 sat's 99%. It's just they're having this sound because of the fixed obstruction in the trachea that's causing the reverberation and the, I can't do the expiratory one, I can do the inspiratory. And then going to flow volume loops, you think this fixed, you have the expiratory and the inspiratory loops, and fixed, you just have something there that is not allowing you to inhale or exhale appropriately and get the volumes that you need like you would up here. And then we've all seen flow volume loops like restrictive for restrictive lung disease, and you have your scalping for obstructive lung disease as well. In trying to relay the severity of this case, this patient had a bronchoscopy. He had a bronchoscopy 2 weeks later as well. And ultimately, he was scheduled to come back for pulmonology follow-up. But unfortunately, we were chart reviewing, going back on amyloid and seeing if we can schedule this gentleman for another bronch and biopsy to further evaluate, and found that he had presented with a hypoxic arrest to an outside hospital. So despite these interventions, everything that was kind of done for him and the improvement after bronchoscopy, his condition continued to recur, and ultimately, unfortunately, hypoxic arrested and did not make it. So if that imparts the severity of the situation to people, then I hope that it does. So these are my references, and I want to say thank you to Dr. Pariyadath, who's my attending, who was working with on the case, for everything that he's done for me. And also to the Southern Medical Association. I'm looking forward to a good day of learning from each other and then listening to all these presentations and letting you guys know that it's not a stressful environment where you need to get up here and stumble through a presentation. All we can ask you to do is your best, and that's all we expect. So I appreciate you guys and looking forward to the day. Any questions that I can answer? Yep. Yep. Probably path, seeing if it is amyloid, and then trach with a bridge to a tracheostomy, like tracheectomy, ENT follow-up, seeing if there's anything in that standpoint that they could do. But yes, if he continued to just close off over and over, he would need to be trached kind of below that point. But as you see, it's kind of at this very low junction, so you can't trach there very well. Yeah, so that's a good question. I think getting ENT involved and getting the path of seeing what it really is would have been beneficial, but unfortunately, we don't know. Anything else? Alrighty, let's have a good day.